Okay, good morning or afternoon, depending on where you are. My name is Tom Lloyd, and I'll be chairing this information session on inclusion body myositis town hall. I'll go ahead and share my screen so that we can introduce all the speakers today. So let me just make this nice and big. So our format is we have actually 6 speakers today, and each of whom will be talking for right around 10 minutes. And then after that, we'll have around a 5 or 10-minute session of question and answers. And then at the very end, we'll have additional questions and answers as well. And so I've listed here the list of speakers and general actual topics of discussion. With that, why don't we actually start with introductions. My name is Tom Lloyd, like I said. I'm a neurologist at Johns Hopkins and co-director of the Myositis Center. And I focus on inclusion body myositis. So maybe Tazeen, you can go next.
Sure. I'm Tazeen Mozafar. I'm a professor of neurology at UC Irvine. Have a long-standing interest in myositis, primarily focusing on antisynthetase syndrome, necrotizing myopathy, and IBM.
Okay, great. Next is Namita.
Hi, my name is Namita Goyle. I am a professor of neurology at UC Irvine. I'm a neuromuscular specialist. I've been very interested in inclusion body myositis. I've been seeing patients for approximately 15 years, and I recognize that there's a huge unmet need, both in the patient management as well as therapies. I'm happy to be here. It's one of my favorite meetings of the year.
Okay, wonderful. Next is Dr. Tae Chung.
Hi, my name is Tae Chung. I'm an assistant professor at Johns Hopkins in the Department of Physical Medicine and Rehabilitation. So given my background, I've been very interested in exercise and rehabilitative intervention for all myositis, but most of my patients at this point are patients with inclusion body myositis. They have unique challenges for rehabilitation. So my interest has been focusing on rehab and therapeutic exercise for inclusion body myositis.
Okay, thank you. Next is Dr. Chris Weil.
My name's Chris Weil. I'm at Washington University School of Medicine in St. Louis. I have both a clinical as well as research interest in acquired myopathies, in particular inclusion body myositis. I have a basic research lab that I participate in about 80% of the time, and 20% of the time I see patients in our myopathy clinic.
Okay, thank you. And last but certainly not least is Dr. Lindsay Alfano.
Hello, I'm Lindsay Alfano. I work at Nationwide Children's Hospital in Columbus, Ohio. Don't be fooled by the name. Even though we are a children's hospital, we do see patients with neuromuscular disorders from birth through adulthood. The research focuses on outcome assessments and trying to reduce the burden of testing for patients while still maintaining the level of consistency and accuracy we need for clinical practice and clinical trials.
Okay, thank you all very much. So I will start off with my presentation, and I will actually start off just with an overview of inclusion body myositis. I'm sure most of you are very familiar with IBM, clinical features, how it's diagnosed, but I know every year there are many patients who are new to the TMA, and actually perhaps aren't sure if IBM is actually the correct diagnosis and are wondering what to expect. So I'll give a brief overview. Inclusion body myositis is the most common acquired muscle disease in adults over the age of 50. It is increasingly common with aging. Now, occasionally we will see patients who have onset of symptoms earlier than age 50, as early as late 30s or certainly 40s, but it is more common after the age of 50. Now, you may hear actual terms like sporadic or hereditary. By far, the sporadic form is most common, and we call sporadic IBM SIBM or simply IBM because it's the overwhelming form of IBM. Now, what is referred to as hereditary IBM or genetic IBM, it's very rare, and it's in most cases really not myositis. So the IBM is inclusion body myopathy, meaning it's a muscle disease. And it is usually diagnosed based on genetic testing. And so we're often asked whether it runs in families. Now, even the sporadic form can rarely be more common in family members, but in general, IBM is not inherited. Interestingly, it affects men about 2 times more than women. We don't really understand why that is. And because many doctors aren't very familiar with IBM, and it also has this very slow onset of symptom progression, there's a dramatic delay in diagnosis, usually about 5 years. Oftentimes, patients will present with weakness in the legs, difficulty climbing stairs or getting up out of a chair, and so it's very common. Initially, patients are told, "Oh, you're just getting older. You need to exercise more," and so the initial diagnosis is usually suspected based on a physician checking what are called muscle enzyme levels, or CK creatine kinase. And usually when those are elevated, that is a sign of an underlying muscle disease. And then further evaluation is undertaken. So the main clinical features of IBM, as I mentioned, it's an insidious onset and progression of usually painless muscle weakness. And the actual pattern of muscle involvement is usually quite characteristic. So it primarily affects the upper muscles in the legs, especially the quadriceps muscles that are involved in knee extension. And it also prominently affects muscles that control grip, your what we call the forearm finger flexor muscles. And in some patients, they will have an early onset of foot drop. And so it's usually this pattern of weakness, at least in neurology, that really makes a clinician think of inclusion body myositis. And then about half of IBM patients will develop swallowing problems during the course of disease. Now, IBM for many general neurologists and rheumatologists is often very challenging to diagnose, and it really relies on a careful history and examination. And the muscle biopsy is required for a definitive diagnosis that will allow someone to participate in clinical trials, although increasingly some physicians are relying mostly on the history exam, and then also what's called the NT5C1A or CN1A autoantibody. So in some cases, when a muscle biopsy is not able to be performed, the history exam and autoantibody can help make a diagnosis. And so what I would like to emphasize here is it's rare that only one test is truly definitive. So it's usually a combination of features. And the sort of atypical features that make us think of other muscle diseases are, most importantly is unusual patterns of weakness. So if it doesn't affect primarily the finger flexors and the quadriceps, then we want to think about other diseases like muscular dystrophy, and certainly rapidly progressive disease, a family history of muscle disease, or in cases where the muscle biopsy fails to show the sort of characteristic features, namely inflammation or what are called rim vacuoles. Those are cases that alternative diagnoses really want to be considered. So one of the things we'll be talking about during this town hall is how to treat IBM. I'm sure many of you have been told by a doctor that there's really nothing you can do. And so one of our goals of this session is really to reinforce the fact that actually there is a lot that actually can be done. So even though we don't have any medications at this point that are proven to be effective, we do know that many different forms of therapy are extremely beneficial. So even though we don't yet have carefully controlled data on trials of exercise, increasingly the evidence both in the literature and in our practices really suggests that exercise does help patients. So it certainly makes sense intuitively, but also in our experience, exercise does seem to sort of help slow progression, at least early in the course of disease. And so we will talk more about physical therapy, occupational therapy, and exercise during this session. One question that we're always asked is whether statins are safe. So statins that are used to lower cholesterol are frequently prescribed in older individuals. It's well known that statins will reduce mortality, reduce the incidence of heart attacks and stroke. And so given the overwhelming benefit of statins in patients with risk factors, and really no evidence that statins are harmful in IBM, we as a community, we generally do advise patients who are recommended to take statins because of risk factors, go ahead and take those medications. So in general, we don't think that IBM has an adverse effect on lifespan. Most patients are able to live a full life. Now, the risk factors for hospitalization and poor outcomes are mainly falls and choking. And so the most important advice that I give to my patients is really to make sure to avoid falls, and physical therapists are very helpful with that. And and choking. And so I strongly recommend any patients who have any swallowing problems to see a speech language pathologist or SLP therapist. And they are experts in evaluating swallowing function. And there are many things that can be done to help swallowing. So here's sort of an overview of the most common types of therapy that most of our centers will offer. So as I mentioned, speech therapy or SLP is extremely helpful for swallowing problems. It's usually diagnosed by what's called a video fluoroscopic swallow study, in which you can really see exactly what the problem is when patients have swallowing problems. And then physical therapy and exercise. Actually, Dr. Chung and Alfano will talk more about this. And then finally, occupational therapy is especially helpful, especially for hand weakness and patients that have significant disability. So I'll very briefly just mention some of our clinical trials that we have underway at Johns Hopkins. Most of you probably know the arimoclomol trial that was completed earlier this year. Unfortunately did not show a benefit. We will be starting a trial of a drug called sirolimus or rapamycin, either at the end of this year or early next year. Right now, unfortunately, there are only 2 funded US sites at Hopkins and the University of Kansas, although Dr. Domachki, who is leading the US effort, is actually trying to get additional funding for additional US sites. You'll hear later about a very important natural history study, which is just about to get started, and also a new clinical trial from Dr. Steve Greenberg at the Brigham, in which the initial phase 1 study is taking place in Australia, and then if all goes well, hopefully many US sites will be involved in that trial. There is a scientific interest group through what's called Imax, the International Myositis Assessment and Clinical Studies Group. And so this is an active group that is really spearheaded by Oscar Roy at Yale. And our goal here is to improve outcome measures for IBM clinical trials. As you'll hear from Lindsay, one of the real problems with IBM clinical trials is the lack of really reliable and sensitive outcome measures. And the scientific interest group has 3 sort of subgroups that are listed there, in which we are trying to develop better patient-reported outcome measures, functional outcome measures, and biomarkers. Our IBM patients who are undergoing a muscle biopsy at Johns Hopkins, we are enrolling them into a study in which we are generating a mouse model of IBM, what we call a xenograft model. And we've been able to show that the mice actually develop what is typically seen in human patients, so including inflammation and rim vacuoles. And so we're excited to actually use this model both to better understand what causes IBM, but then also to actually test drugs in a mouse model before starting them in patients. And so this is my last slide. These are some of the drugs that we have either started testing in the mouse model or are in plans to start. So rapamycin we're going to test, since it's just starting in a clinical trial. A drug called sodium phenylbutyrate, which has shown promise in ALS and in in vitro studies in IBM. There's a company some of you may be familiar with called Avogen, which has a what they call second generation myostatin inhibitor, which is a gene therapy that is basically designed to accelerate muscle growth. A brand new company that just formed a couple months ago, known as Abata Therapeutics, has what they call Tregs, regulatory T cells, and the idea here is that if you inject them into the mouse or eventually into patients, that it can modulate the immune system. And you'll be hearing from Dr. Goyle about an antibody called anti-KLRG1 from Abcuro that I mentioned earlier, developed by Dr. Steve Greenberg, and that we're hoping to also test in this model. So I will end there, and thank you for the funding sources. And I will look for questions in the Q&A and the chat. Okay, so we have a question on sirolimus. My rheumatologist has prescribed 2 milligrams per day sirolimus tablet on an experimental basis based on Dr. Benveniste's phase 2 study. Can you give a simplified description of what the drug does in the body and how it may stop muscle atrophy in patients that a layperson could understand? Yeah, this is a great question. I know in Europe, there are physicians that are prescribing that based on Dr. Benveniste's phase 2b study. In general, I have not been recommending it simply because our experience is that in very small studies that are a single site, it's really hard to know whether it's truly efficacious. The reason why the FDA requires usually multiple phase 3 studies before approving is that it's really hard to be confident that a drug is effective, and especially since we do know sirolimus, which is FDA approved for actually transplant rejection, does have significant side effects. Importantly, it actually suppresses the immune system, and so in particular in this era of COVID, I am reluctant to prescribe an unproven drug. Now, in terms of the proposed mechanism, so it does suppress the immune system, and of course there is an idea that maybe the immune system is playing a role in IBM, although other immunosuppressants really have not shown efficacy. But really the main idea is that it induces what's called autophagy, and the autophagy process will actually break down aggregates. So what we see in inclusion body myositis, the so-called inclusions are actually protein aggregates that we think are toxic to muscle cells. And so the idea of sirolimus is that if you can sort of stimulate your natural autophagy process, maybe you can actually get rid of these toxic aggregates. Yeah, does anyone else on the panel want to comment? I know actually, Dr. Weil, you've studied this drug in a mouse model of a VCP-induced IBM.
Yeah, so I think your summary definitely of our apprehension of prescribing the drug is true. I think the trial, as I read it, the phase 2 trial, was that the drug was somewhat safe. It didn't really show a clear efficacy. It did in some patients, but there were some patients that stopped taking it because of significant side effects. So I think that's important to reiterate. As far as the mechanism of action, I think the goal is that rapamycin could focus on both arms of what we think is the pathogenesis in IBM, one being the inflammation. It is an anti-inflammatory medication. It's not the exact anti-inflammatory medication that can affect T cells, so it's not perfect for that. And then the other is that perhaps it can increase this process called autophagy. Autophagy is the recycling of cellular components. And one thought is that as we age, we accumulate undegraded proteins as well as unrecyclable parts of the muscle. And that's the reason we see the inclusion bodies and the vacuoles, which are hallmarks of the disease. And that perhaps if we could enhance this process, we could improve muscle function. All of that is theoretical. And even the current clinical trial that's being done isn't going to answer the question, did we activate autophagy? Did we actually clear out these protein aggregates? It will answer the question of, do patients improve, which is absolutely probably the most important question. But the theoretical reasons of why this works still might remain theoretical.
Okay, great.
Yeah, I just wanted to add, Dr. Lloyd, that I echo your thoughts completely. I studied the phase 2 study, and it was only 44 patients. So 22 were on treatment, 22 were on placebo. A pretty small number as we're learning about clinical trials moving forward, that it doesn't necessarily represent the entire IBM population. We're learning that IBM is pretty variable with disease presentation. The primary outcome measure was actually not met. It was to increase quadriceps muscle strength. It did show some interesting secondary outcome data, that the 6-minute walk test was improved at 12 months. And they also looked at muscle MRI of the thigh muscles, and they saw that patients that were treated had less fatty replacement than patients that were on placebo. So those are interesting data points, and I think that's what generated enthusiasm to move forward with the phase 3 study, which I am entirely supportive of, and I think we should be doing. But prescribing it off-label at this point is, in my opinion, dangerous. As you mentioned, it's an immunosuppressant and can cause side effects.
Okay, thank you. Yeah, there's a question here in the Q&A about how the actual dosage was determined in terms of 2 milligrams daily. I don't know the answer to that. Does anybody know the answer?
I think they just guessed. I mean, I think patients need to recognize that this is a clinical trial where it was an exploratory clinical trial. There's a phase 1 trial and a phase 2 trial. And so this was still in kind of the exploratory phase. And one of the outcome measures or one of the outcomes of this type of trial is it safe? Is it tolerated? And those are really some of the most important things in these types of trials. So I don't know the answer, Tom, but my guess is, in thinking about clinical trial design, is it was some empiric.
Yeah. Okay, well,
my understanding, Tom, is that they borrowed from the transplant literature. So that the usual dose in the renal transplant is 2 to 3 milligrams. The bigger question is, because in the transplant, you dose based on the blood levels. And if I don't know the trial design for the sirolimus trial, if they're going to be adjusting the dose based on the blood levels or not.
right. Okay, so why don't we go ahead and move into the next presentation. Dr. Mozafar, I think you're next, and everyone, please keep asking your questions in the Q&A, and then what I'm doing is asking them sort of in coordination with everyone's talk, so that our questions are most relevant to the speakers. I'm not able to hear you, Dr. Mozafar.
Yeah, that's the biggest problem with Zoom, is that it takes you time to figure out how to unmute yourself.
Okay.
But thank you. I just wanted to quickly update folks on the natural history study, and I think some of the folks in the audience have heard a lot about it over the last few years. It's been a labor of love. It took us about 3 years to get this study funded, but the exciting part is that we are about to start recruitment. So I think a general knowledge of the natural history is important. So the study has a long title, which we use for the NIH submission, but the short title is Inspire IBM. And again, Chris Weil is responsible for this. So send him any criticism if you have of the name. But the idea is that I think there is so much new that we can learn from this study, and hopefully that will inspire future trials and studies in IBM. So this was, again, the idea came out of this paper that Dr. Goyle was the first author on, and this is a first attempt at looking at whether the antibodies in IBM, the anti-5C1A antibodies, had any predictive value in terms of disease course or disease behavior. And this was a small study, so I want to start off with that with a disclaimer that it was only about 25 patients. They were all seen in a clinic setting, and we had about 7 seronegative patients and about 18 seropositive patients. So the numbers are small, but even at that small, saw some interesting findings. So one of the more interesting finding was a striking differences in terms of proximal muscle weakness in patients who were antibody positive versus antibody negative. There was also differences in lung capacity or breathing capacity, which we typically don't think about issues with breathing in IBM, but the more you look for it, the more you find it. And then there were differences in needing assistive devices, where seropositive patient or antibody positive patient requiring a lot more assistive devices than patients who were negative for the antibody. And the presence of swallowing difficulty was much more in patients who were antibody positive. So this sort of hinted at the idea that there may be differences in patients who are antibody positive versus negative in terms of disease behavior. And then the next question we asked was whether there is any evidence that they may, in the long run, do worse or they progress faster. And then a related question is whether they are likely to respond differently in terms of treatment, if there is ever a treatment available. The aramoclonal study actually collected blood on the antibodies, so hopefully we will know the answer at some point when they get around to analyzing those specimens on that. But then there was another interesting paper from James Lilliker's group in the UK, and this was actually a multi-European consortium, where they hinted that the disease progression was different in the sense that the life expectancy in patients who were antibody positive seemed to be lower than patients who were antibody negative. Now, Chris Weil, as part of his study, actually has re-looked at this with Chesiko Egenaga, and they showed there was no difference in patients. There was no difference in life expectancy, but it was interesting that when we contributed about 65 patients to that cohort of patients, and for some reason at UCI, we still had a trend towards a lower life expectancy, but the overall study did not suggest that there was any difference in life expectancy in Chris Weil's cohort of close to 200 patients on that. So again, it remains somewhat unsettled whether there is a difference or not. But this paper from the Japanese group, Tawara's group, was actually interesting where they did a simple experiment where they took blood from patients with IBM and see if there was a difference if the blood came from patients who were antibody positive versus antibody negative. And they took that blood and they put it on muscle cultures, but they also passed it on to mice and showed that only blood from antibody positive patients actually created pathological changes in the muscle culture as well as in animals with a lot more of what's called P62 positive inclusion. Again, suggesting that they may be at the molecular level or cellular level, there may be pathophysiological differences between the two different types of patients or disease. The other challenge that I face, and especially when we talk about expensive multi-center trials, is that we still don't have a good understanding of what the disease progression is, and it's been not really been studied very well. Most of the studies have not gone beyond 1 year, and the studies mix and match different data sets, which has been a challenge on that. And then none of these studies really looked at the biomarker, so that we now have the antibody biomarker, and we need to understand if the antibodies influence the disease in any way. And Dr. Greenberg found these variant lymphocyte population or highly differentiated T cell population. We don't know whether that influences the disease progression or not. So the question is whether the rate of progression is different, whether or it's going to behave more like ALS, where some patients have a faster progression, some patients have a slower progression. What is the general rate of progression over a 2-year or a 3-year period? And unless we know this stuff, it's going to be very difficult to design good trials where we can clearly, definitively answer whether a treatment works or not. Dr. Alfano, on a separate related issue, is working on what's the best outcome measure, which is how the measures that we use, whether it's IBM-FRS or 6-minute walk test or muscle strength testing, are they really as sensitive as we think they are in terms of predicting disease response? So there is a list of questions that we have raised and unmet needs that we have raised that needs to be addressed in that sense. So based on these, we designed a prospective non-interventional, and I would emphasize the word non-intervention. There is no drug being tested here. This is purely an observational study. I want the patients to be clear that if you volunteer for this study, you'll not be getting a drug for that period. We want to address the issue of whether the anti-5C1A antibodies influence disease progression, and we are hoping to study these patients for a 2-year period. This is a great opportunity to do a sub-study where we will be looking at muscle biopsies and see if there are differences in muscle biopsy pathology from patients who are antibody positive versus antibody negative, but it also allows a unique opportunity to do additional deeper studies using all the modern technology in a group of very highly characterized patients where we know their disease history, we know their outcomes, we know their status at this point. And there are some really cool technologies right now, including the stuff that Dr. Goyle is going to talk about in terms of genetics, what Dr. Lloyd is doing with single cell RNA sequencing, but there's also some new imaging technologies that we can use. And then we also want to look at distribution of these highly differentiated cells. And then because of my interest in respiratory functions in IBM, we thought this would be a great opportunity to fully evaluate if the respiratory system is involved and what the rate of progression there is. So again, I'm not going to bore you with the different hypotheses, but the primary hypothesis is that we think the disease progression is going to be different based on whether you have antibodies or not. And it's going to be a 2-year study with 5 time points of data collection. So each patient is going to be seen 5 times with multiple measurements, multiple blood draws. We are collecting RNA and DNA in all patients. And as I said, there is a 40-patient sub-study where we're going to be collecting fresh open muscle biopsies to look at the pathology, but also store these muscles so we can do additional sort of fancier studies down the road. And then we want to further characterize these highly differentiated T cells, and again, collecting muscle as well as blood at the same time. So you can cross compare whether the changes that we see in the blood also happen to be in the muscle on these patients. So again, some pretty pictures of how we analyze it, but really not relevant to this discussion. And then following respiratory function in a longitudinal fashion. We have some preliminary data from our clinic population that the seropositive patient or antibody positive patient may have a different decline rate than patients who are seronegative. But again, these are not enough patients to make a definitive conclusion. So we want to look at it in more details on that. We did the sample calculation. We thought 150 patients is going to be a good size. We are hoping to get about 100 antibody positive and about 50 antibody negative patients. That's based on our experiences so far over the last 5 years, that if you do a random collection of patients, it almost turns out to be 66% are going to be antibody positive and about 34% are going to be antibody negative. And that's true for Dr. Goyle's study. That's true for Dr. Weil's recent study as well. So that's been generally our experience with that. There are 13 sites and they are distributed throughout the US. We are conspicuously missing sites in the Southeast, especially around Florida and that, but we have great sites in Houston, in Dallas, as well as in Baltimore. So that's how it evolved eventually. We did a lot of groundwork before this. We actually sampled the patient population, and some of you may have participated in these questionnaires that were sent out online. I really appreciate your help in getting us to this stage. And one of the things that we found out was that patients are willing to help out in any way possible. They have no qualms about participating in a non-interventional study. They are even volunteering to undergo blood collections, muscle biopsy, which is very heartening to hear. We also put together a community engagement studio where we brought in 10 patients and caregivers with IBM in a small meeting in San Diego, and was moderated by a former dean of the nursing school, where we sort of really asked the stakeholders what's important to them so we can design the study much better. Both aspects of the grant, when we put in the story about the community engagement studio as well as the patient survey, was really liked by the reviewers and featured very strongly in the decision to award this grant. So I want to thank patients and caregivers who participated in these efforts. It is finally funded. There are 13 sites. We are slowly getting them up and running. We are using a single IRB, which is out of Kansas City. The first patient is going to be enrolled either at UC Irvine or Kansas. We're hoping end of September. But the other sites are slowly coming up online as well. So we should be fully enrolling by end of this year. Touch wood that we won't have any other resurgences in COVID infections. And again, one of the great opportunities from the study is that we will be able to create a large repository of lymphocytes, blood cells, DNA, RNA, and muscle tissue from a group of highly characterized and phenotype patients that we can use for future studies. So I'm going to end here. I'm happy to take any questions or comments from the panelists as well as from the audience.
Okay, great. Yeah, there's a question regarding exclusion criteria. So are individuals who are actually 10 years past a diagnosis of IBM excluded?
Yes, so that we wanted to avoid any changes related to scar formation or disease, muscle atrophy, or thing. So we had decided early on in the planning stages that we will limit the inclusion to patients within 10 years of onset. The other exclusion, primary exclusion, would be patients who are participating in an experimental drug trial, because that may influence the natural history. So at this point, we would not be including those patients in the study.
Okay, great. That makes sense. And also a question whether NT5C1A is actually being looked at in other clinical trials that have been already completed, such as arimoclomol. Do you know if actually Dr. Damachki is planning on looking to see whether NT5C1A positive patients might have had a benefit?
Yeah, so I know that it took me a lot to convince them, but they finally did get convinced. So I know that the blood and serum was collected from patients. It is in storage right now in the UK, and they were planning to analyze it in a laboratory in the UK. But I don't know if they have done it or not. I mean, one good thing that will come out of that trial, even, and it's unfortunately the drug did not work, but we have the placebo arm, which were followed systematically for about a year and a half. And so we will at least have some semblance of a natural history data coming out of that study as well.
Okay, great. There are a number of questions actually regarding the autoantibody test. So I know some labs will report sort of low positive, moderate positive, high positive. Are there particular labs that you find more reliable? Maybe you could answer this as well as actually Dr. Weil.
Well, I mean, so I think both of us will have a little bit of a biased opinion because we only use the Washington University lab. So we've been sending pretty much all our testing to WashU, and Chris obviously lives in WashU, so he does it locally. I'm not sure that I have enough experience with other labs doing it on that. Maybe Chris, you may know this answer better than I do.
I mean, I think it's a problem with all antibody testing for myositis in general, is that labs do their assays differently. And so the ones that we do here at Washington University is done differently than it's done for the other commercial place that it can be done in the United States, which is RDL. RDL uses a different approach. And so what does that mean? That means that the sensitivity and specificity for the antibody is different from patient, or different from lab test to lab test, from where you're getting it done. And so I'll talk very briefly when I talk, but that was the reason we did our study, was really just to show what the sensitivity and specificity was with the WashU assay. Very well, you could do that with another assay and find something different. I don't think there's a right or wrong answer. I, of course, would say send it to us, but I know that we think our sensitivity and specificity is higher than what has been reported by the other labs. I don't know if that necessarily means that it's a better test, to be quite honest, because we're actually finding more false positives as well. And so I think in the context of being seen by a neuromuscular physician, if you have a high false positive rate and you've been seen by a neuromuscular physician, they should be able to recognize that, no, this really isn't clinically helpful. So I think it goes back to the usefulness of the test for different providers.
So the other challenge, and so RDL was the main reference laboratory for rheumatological antibody testing. Unfortunately, they sold their business to a commercial lab. And over the last 2 years, there's been inconsistency of how they've been testing their antibodies as well. It's done through LabCorp, but it's done through a subsidiary of LabCorp. And all of a sudden, we're seeing a whole bunch of false positives as well on that. So it's as Dr. Weil mentioned, it's a big issue in myositis right now. because every lab does it differently. Every lab has a different methodology and lower cutoff rates versus higher cutoff rates. So you have varying degrees of sensitivity, etc. So that's an area that the Imax group as well, there is an international consortium that is looking at that issue right now, is how do you standardize laboratory testing of these various antibodies, be it IBM, be it dermato, be it necrotizing myopathy.
I think, I know that I'm pretty confident that Hopkins uses a different approach than what we use. And so I think some of it has to do with the clinician's experience with the testing lab that they're using. And so I think that's probably part of it. So I would suggest that your clinician be the one that decides where they feel most comfortable getting it tested.
Right, yeah, I would echo that. We've been actually mostly sending ours to RDL, and as you mentioned, they use a ELISA test, and actually have like a moderate positive, low positive, or actually high positive. And so I'm when it's low positive, I've definitely seen a lot of false positives there. Whereas if it's high positive, I am more confident in that result.
I would correct really quickly whenever we're talking about tests that are positive, tests that are negative. All we're saying is that it has nothing to do with, it's not a diagnostic test at this point. It's just not good enough for a diagnostic test. So it's a positive test doesn't mean you have IBM. A positive test means that you have NCC5-1A autoantibody in your blood.
Right.
And what that means is entirely unclear. So I see a note in the chat that says, having 2 positives from WashU over a period of 5 years, would that change my confidence in positive? I guess, are you asking would that change my opinion about what your diagnosis is? No, it wouldn't. But I would say you're positive for the antibody. But I don't know, that's not how we use this test. It's not that good of a test for diagnosis.
How often are you seeing it in normal individuals, a positive test?
So I don't know if I can say normal individuals, because we don't, as a lab program, we don't, we just don't do lab tests on normal people. But on patients with other muscle diseases, we see it about 20% of the time in patients with other muscle diseases. And
oh, wow.
So, we're seeing it 80% of the time in patients with IBM, and 20% of the time in patients without IBM. One new piece of data that we have, which is that if you have a biopsy that shows inclusion bodies in myositis, your antibody is 95% of the time positive. So there is a good correlation between biopsy and antibody, but I want to be careful. We need to actually move away from diagnosing patients with biopsy. We need to be thinking more about clinically diagnosing patients. So all of it gets very messy, and it's really, as Dr. Lloyd said in the beginning, there's not one single test that really diagnoses it. It's an integrated kind of workflow, and these are all tools to help add it to it.
Okay, thank you very much. Why don't we move on to our next speaker, Dr. Goyle?
Can you see my screen?
Yes.
Yeah, great. Hi, everyone. I'm glad to be here. I wanted to give you an update on 2 projects that we're working on, in addition to the natural history study at UC Irvine. The first project I'll talk about has to do with giving you a little bit more insight into why the Abcuro study or the clinical trial that's up and coming, it seems really interesting and exciting. And then the second one just has to do with some outcome measures that we're looking at. So as some of you have heard, Dr. Greenberg and others have described that many of the CD8 positive T cells that we see as potentially disease-causing in IBM express KLRG1. And KLRG1 is this marker of highly differentiated cytotoxic T cells. Cytotoxic T cells means that these are cells that potentially are disease-causing or damage muscle in IBM. And these cells are actually found in IBM muscle and blood. And so there's been this hypothesis that these are the cells that may be actually disease-causing or pathogenic in IBM. These cells, the highly differentiated cytotoxic T cells, are actually known to be refractory to standard immunotherapy. So some of you may be asking, well, if there's inflammation in the muscle, why doesn't it respond to immunosuppressive therapies like steroids and other agents? And this is one postulated reason is that these cells are so highly differentiated that standard immunotherapy just doesn't help. And so we were interested in collaboration with Dr. Greenberg and our immunologist at UC Irvine, Dr. Villalta. Dr. Mozafar and I were interested in learning a little bit more about KLRG1, learning what it means in the T cell subpopulation, and if they're actually present across all T cell subsets. And so we did immunophenotyping on the blood of 50 IBM patients. So really took the blood samples of 50 IBM patients and looked at their T cell population. And what we found on the left side here, you can see that KLRG1 expression is lowest amongst T regulatory cells. I think of these as our, good cells, but was highest and greatest amongst the CD8 positive T cell population. And so when you look at the CD8 T cell subsets, these are the different T cell subsets that you're seeing. We noticed that KLRG1 expression was lowest amongst the naive T cells, but with T cell differentiation, KLRG1 expression increased and was highest amongst the highly differentiated effector memory cells. And normal is bubbled in white, and the blacked out or gray are the IBM populations. And you can see that it's pretty significant at the more highly differentiated T cell population. We also looked at disease duration, and what you'll see here is that there's this positive linear correlation with disease duration, so longer disease, to the proportion of CD8 positive T cells. And on the right, you can see that there's an increased expression of KLRG1 with greater or longer disease duration. So we believe, based on these findings, that patients with IBM that have longer disease duration have even greater T cell differentiation. We also looked at disease severity, and this is characterized by the IBM functional rating scale. As many of you know, 40 maximum is normal function and 0 is severe function. And what you're seeing here is that KLRG1 expression seems to be present despite disease severity. So people with milder disease, as well as patients with more severe disease, have KLRG1 expression. And so these findings have really generated enthusiasm that KLRG1 may be a potentially attractive drug target. If we target KLRG1, can we deplete the pathogenic cells? And so Epcuro is a biotechnology company that's been founded by Dr. Steve Greenberg. And they've developed a drug called ABC008. It's a KLRG1 anti-KLRG1 antibody, so targeting KLRG1 specifically in hopes to deplete these highly differentiated T cells that we believe are cytotoxic or cause destruction to the muscle in IBM. And it's exciting to know that despite COVID, phase 1 studies started this past year in Australia. I believe they're targeting 27 patients enrollment. And we're anticipating that these results will be coming up next year, and we'll hopefully learn if we're going to be moving on to phase 2 studies with potentially sites in the US. So that's some insight into the KLRG1 study. And then I also wanted to just briefly talk about some of the outcome measures that we're looking at. So as many of you know, IBM Functional Rating Scale, or the IBM FRS, is already a validated tool that is used in most clinical trials and even in the clinic setting to help monitor disease progression. As I mentioned, the maximum total score is 40 with indicating normal function. And it's been previously studied and shown to correlate well with muscle strength measurements, which is why it's being used in trials. So manual muscle testing, as well as hand grip measurements that we use a dynamometry to measure. But Dr. Mozafar and I were interested in figuring out, there's several other measures that we look at, both in the clinic setting as well as in clinical trials. And if these measures also correlate with IBM FRS to potentially further characterize disease state. And so we did a cross-sectional study of about 50 patients, and we looked at IBM FRS versus several outcome measures. And what you're seeing here is we found, as similarly reported, that there's a strong correlation with IBM FRS to muscle strength scores. So patients that are stronger also had higher scores of their IBM FRS, which seems consistent, as well as what's been previously reported that hand grip measurements do correlate with the IBM FRS questionnaire. But in addition to what's been previously reported, we also wanted to look at other outcome measures. As many of you in clinic know, we monitor forced vital capacity in the clinic setting, as well as in clinical trials. And we saw a good correlation with FVC. So patients that were stronger on the basis of better function based on their IBM FRS also tended to have higher forced vital capacity scores. And we're also interested in looking at a new scale in IBM, but a tool that's been validated in another neuromuscular disease called myasthenia gravis, and that's the MOBFRS. It's a tool that has been validated to measure bulbar, facial, and respiratory muscles. And because these muscles are also involved in IBM, Dr. Mozafar and I have been looking at if this may be a useful tool to help monitor our patients in IBM. And we actually found that there's also a good correlation with the IBM FRS. So this scale, 17 is the highest scale in the OBFRS, and it shows severe dysfunction. 0 is normal. And what you can see here is patients that are weaker with their bulbar, facial, and respiratory scores based on the MOBFRS also consistently had lower scores with their IBM FRS. Interestingly, we found very strong correlations with timed get up and modified Rankin. So as Dr. Mozafar mentioned, timed get up is being used in clinical trials as a very useful measure to measure your proximal muscle strength of your thigh muscles. As many of you know, difficulty arising from a chair is one of the first symptoms in IBM, and is being looked at in clinical trials. It was looked at in the arimoclomol trial as well. And so what we noticed is that patients with milder disease based on the IBM-FRS also took less time to rise from a chair, but those patients with more severe disease based on their IBM-FRS took much longer to get up from a chair, also indicating that this may be a useful tool to use moving forward in clinical trials. Another scale we looked at is the modified Rankin scale. This is a scale that assesses disability, with 5 being the most severe disability and 0 being no disability. And we also found a very strong correlation with IBM-FRS, suggesting that patients with milder disease had less disability based on their modified Rankin scale. And those patients with more severe disease based on the IBM-FRS also were noted to have more severe disability. And then lastly, we even found pinch correlates with IBM-FRS. So if you remember, the IBM-FRS has 10 questions evaluating different functions, rising from a chair, climbing stairs, swallowing, and fine coordination. And so it was interesting to note that even pinch measurements based on dynamometry correlated with the IBM-FRS. So those patients with low IBM-FRS scores had a lower pinch ability and vice versa. So what does this all mean? Well, basically what we wanted to see was we do check all these different measures when you come to clinic and in a clinical trial setting. And are these tools actually useful or not in potentially capturing disease state and progression? And this has become of particular interest to us because while the IBM-FRS is a useful tool in characterizing disease progression, there's still varying reports in the literature of how fast people decline per year on the IBM-FRS. So there's reports saying that people decline 1% per year, but there's also reports saying that they decline 6% per year. And this can become a little bit challenging when you're designing a clinical trial that might be 6 months or 1 year. And if there's minimal change, like 1%, you may not be able to pick up or detect drug efficacy on IBM. So we thought, let's look at these other measures and see if they may be useful in looking at to help characterize the rate of disease progression, the rate of decline in these measures, hopefully through the natural history study that Dr. Mozafar has planned. We're hoping to get a better assessment of how fast all of these measures may decline. Ultimately, really the goal is to improve clinical trial design so we can select the best outcome measures to really capture the drug or therapeutic effect in a small amount of time. None of us want to do clinical trials with a drug for 2 years. We're hoping to do it in the shortest amount of time, but use the best outcome measure to actually capture the drug effect and hopefully advance drug development. So that's my last slide, and I'm happy to take any questions.
Dr. Goyle, if you don't mind going to the figure on the different lymphocyte subtype comparison, I just wanted to make a point relevant to Tom Lloyd's, this one. So again, Dr. Lloyd's mentioned that there is a company called A-beta, which is looking at Treg. And one of the interesting findings that we didn't talk about, whether there seemed to be an inverse correlation between the KLRG positive CD8 and Treg, and it almost appears that the Treg population in IBM is getting suppressed. And so one treatment strategy may be to upregulate the T regulatory cells. So one obviously strategy is to deplete these KLRG positive cells, but the other treatment strategy, and this has been looked at in ALS and other degenerative diseases as well, but one potential strategy would be to upregulate Tregs, which is easier said than done. But I think I just wanted to give some sort of story behind it, especially since Dr. Lloyd was talking about this new company.
Absolutely. Thank
Okay,
you.
thanks. There's a actual question in the chat, Tazeen, about the actual status of dilazotide.
Yeah, so we are still, the challenge is that so far the data we have has not been that convincing about the KB 1.3. So at least in the flow cytometry, the KB 1.3 population is only slightly increased. It doesn't seem to be the major driver of the disease. We are trying to do some additional experiments, but we are still in communication with the company, which is based out of Columbus, Ohio, in Dr. Alfano's backyard. So we are still hoping to get that drug up and running, but the data, so we've not had strong preliminary data so far.
Okay, thanks. In your natural history study, how many in-person visits at each of these clinical sites are required?
So it'll be 5 per patient. So it's baseline, 6 months, 1 year, 1.5 years, and 2 years.
Okay, perfect. Thank you. Okay, why don't we move to the next speaker in the interest of time, Dr. Weil? I think you're up.
Oops. I thought it was Tay. Right?
Sorry, Dr. Chung.
Right.
My fault.
Thank you. All right. Okay. Can you see the slides or?
Yes, go ahead.
Okay, sorry. Again, my name is Tae Chung. I'm in the Department of Physical Medicine and Rehabilitation. At the same time, I'm a neuromuscular doctor. I'm seeing a lot of IBM patients, as I introduced. Be interested in rehab and exercise intervention for IBM patients. And with this talk, I'm going to switch gears a little bit and talk about more practical and clinical aspects of IBM care. And basically, this is a short 10-minute talk and kind of answer to a lot of questions that I get from my patients. Basically asking, well, what kind of exercise should I do? And well, where's a YouTube video for that? And where's a list of exercise? Can I just kind of hand it out to the patients? It was a little bit more complicated just than that. I wish it was that simple. And I want to explain the rationale behind that. So for exercise intervention as a rehab doctor, there are basically 2 aspects of rehab and exercise intervention. One is more therapeutic approach. Basically, we are considering exercise as a therapeutic intervention to improve muscle weakness or even maybe delay the progression of IBM per se. And also at the same time, there is a rehabilitative intervention. What I mean by that is more compensatory mechanism. We are not really addressing the disease itself. I know previously I was talking about drug intervention to address their pathophysiology, but what I mean by rehabilitative intervention, so when we try to use whatever patients have to, keep the function. So for example, as you know, IBM affects different muscles differently. There are muscles like forearm finger flexors that are much weaker than extensors, for example. Then we try to train extensor muscles that's intact to compensate for some hand functions. Or we can use orthotic or brace in the ankle to prevent falls. And for IBM in general, because their sensory functions are intact, there's a lot of things we can do to prevent falling. I call this more mechanical falling. So it's relatively easy to prevent falling if you understand their gait pattern and if you prescribe right type of braces. I'm not going to talk about too details about what kind of braces we do per se, but talk a little more about the therapeutic exercise.
Would you mind switching out of the actual presenter mode?
Okay.
I think there's a
Is this
way to show the whole screen
maybe is this better?
under display settings.
Yeah. Sorry about that. Is this okay?
Okay, yeah. Now in the bottom right, if you click the one that looks like a screen, it'll blow it up. Do you see that icon on the lower right?
Display.
No, over to the right. Over
Mhm.
over two more. Two more. One more. There, that one. If you click that one. Yeah.
That's what I did.
Huh. Okay. Yeah.
Should I just get out of this?
Okay. Yeah. That's better.
Is it better? Do you want me to just?
Yeah, I think it's better. Yeah, you can go ahead.
Okay. Sorry about that. Okay. So to provide exercise as a therapeutic intervention, we'll have.
Sorry, it's actually not advancing. There should be a way to play your slides. Someone said click on slideshow.
It's advancing to me, my screen.
Or slideshow play. Does anybody else have any? Yeah, if you see on the top where you click on slideshow.
So Tay, up by home, insert design animation slideshow, maybe clicking on that
Well,
one.
I think you're probably, oh, hold on a second. You're seeing different.
Yeah, we're seeing something different than what you are.
Yeah, definitely. I think, okay.
What you were showing before is better. It's just smaller.
I think I know it. Okay. I think I know what to do. Okay, hold on a second. Apologize for this. I have to How about now? Can you?
Yeah, there you go. You got it.
Does it move? Okay.
Yeah.
Okay, I'm sorry about that. Yeah, I think it's a Zoom. Apologize for that. Okay, anyways, so for exercise, to provide therapeutic option for exercise, we'll have to prescribe exercise. I know some of you may have heard about exercise as a prescription. Just like we prescribe medication with the exact dosing and frequency, exercise should be prescribed, and that's in our clinic center, that's something that we try to do. It's not that easy, but something that I'm trying to set up, trying to do for the patients. So to prescribe exercise as a therapeutic intervention, well, I think patients have to really understand there are different kinds of exercise, just like there are different medications for different purposes. Exercise have different purposes, such as endurance, cardiovascular, exercise, basically the strength and heart and lung, and resistance. And muscle has different quality, which is endurance quality and resistance quality, and basically depending on different type of and different types of exercise target different qualities of these muscles. And also there are different dosing for exercise, how basically is the amount of exercise you have to do to achieve those goals. And to prescribe exercise, we need to define the goals first, and then what we should target. I think I saw somewhere in the question about balancing cardiovascular exercise versus resistance exercise. And again, that really depends on what goals patients try to achieve. I mean, for the most part, for IBM patients, it affects more elderly population. So cardiovascular training was recommended by American Association of Sports Medicine. They have to do 3 times a week at least for 45 minutes. So that's something they should include as a baseline on top of IBM exercise if you want to target specific muscles. And also to prescribe exercise, we need to be able to measure the strength accurately. So, for example, before the exercise, we need to know where patients are at in terms of their muscle strength or clinical activities. Some of the outcome measures that Dr. Goyle mentioned in the previous talk, we'll try to use some of them, not for the research use, actually for clinical use. And that's really, necessary if you're trying to do therapeutic exercise, because we need to know where they're starting at, and we need to know the progression more in an accurate way for us to be able to prescribe exercise accurately. There are a few ways to do that, like we use some measurement tool called functional index. I'm gonna skip this. So for we use some measurements such as functional index 2 that was actually developed for not just IBM, but for also poly and dermatomyositis as well. But we've been using this quite a while for both IBM, and this is actually an excellent tool for us to kind of evaluate where they are at in terms of muscle strength. And the great thing about FI2 is it's standardized and quantifiable, meaning we can score them, we can compare the scores. Recently, we've been actually using more of the hand grip strength a lot. And the great thing about hand grip strength is that there's a lot of normal values for certain age and sets. So we are comparing their grip strength to the normal population value. Also within the same patients, we are tracking down their grip strength. And this is one of the things that we've been using more often for IBM patients. In addition to that, we also use IBM FRS and other questionnaires that we can score them to compare before and after exercise. Now the type of exercise, again, cardiovascular is really trying to target their heart and lung function. Endurance is really to increase repetition values of muscle. Resistance is more for the weight. And we know that IBM patients, their muscle quality, both endurance and resistance qualities are affected. We also train balance and flexibility with advanced aging. We don't see a lot of balance problem in IBM patients in general, but they do have a lot of flexibility issues as well. Another thing that I want to briefly mention is the side principle in exercise, specific adaptation to imposed demand. It's a fancy word, but what it really means is that you only strengthen your muscle that you're targeting. It sounds like very common sense, but I get a lot of these questions from the patients. Well, I'm walking every day, an hour. Is there an exercise? And I don't think I have to do any more exercise. Well, again, I think patients should really consider this side principle. When you walk, you may target cardiovascular depending on how aggressively you walk, but maybe you can target some of the muscles in the legs, but you're not really targeting any of the forearm muscles, right? And for example, and some other patient will say, I'm doing biking, stationary bike, is it enough for my exercise? Well, it depends on what you're talking about. If you're gonna target, again, forearm muscles, you really need to do the forearm muscle exercise on top of stationary bike. So it sounds like kind of common sense, but this is one of the most common questions that I get from all my patients that come to the clinic studying exercise and planning for exercise. So
we're running short on time, Tay. Are you almost done?
Yeah, I'm almost done. Yeah. Okay. I'm actually. I just want to get to the last point, last slides right away. Then. So how things work for exercise prescription. Basically, as a physician, we prescribe kind of principle and how we do the exercise. And then we basically talk to physical therapists who can individualize your patient's exercise, and they basically give you a detailed protocol. And then depending on the response, we'll modify that. So there are 3 parts involved in exercise prescription. And as you can imagine, this is really not that easy to be done. A lot of patients are coming from out of states, and the communication is not always that easy. So this is really the last slide that I wanted to show. The communication is really important. And I want to emphasize that really the network between different clinical centers and local therapists have been really important to really implement therapeutic exercise as a prescription. So this network, TMA network, is also very important. And again, this is my last slide. I take any questions.
Okay, thank you. Yeah, what are your thoughts on actually blood flow restriction? There's a few questions on that.
Well, to be honest, I know I have a very mixed opinions about it. Sorry about that. So I have a very mixed opinions about blood flow restriction, BFR exercise. First of all, I was actually been very reluctant to recommend BFR exercise. I really, I did see review some previous clinical trials for BFR exercises. They're showing some clinical benefits. They use a lot of different outcome measures, and only some of the measures showed some very mild benefits. And most of their studies are really not controlled between a BFR and just exercise without the BFR. They're actually just comparing BFR and control without exercise. And most of the studies that I've seen from BFR exercise are just could be just from exercise effects, not particularly for BFR. I'm actually a little concerned about restricting the blood flow to the muscle could potentially cause damages. However, I trust our therapists, their experience, and a lot of my therapists who are very experienced, they feel they could be also biased, but I respect their clinical kind of intuition. And one of my therapists actually really strongly believe there's something about BFR exercise different from just regular exercise. So I still have a little bit mixed opinions about it, although I just fully warn them about potential muscle damage because of blood flow restriction.
Okay, thanks. Yeah, actually, Lindsay or anyone else, do you have anything to add on BFR?
No, similar. I'd say in my experience, any benefits that we've seen have been very short term and not necessarily worth the extra effort, I guess. But again, I think there's additional ongoing studies. We do recommend exercise regularly in our patients.
Okay, great. Thank you.
I would agree with Tay. The data is not well controlled, and the positive outcomes are comparing nothing to blood flow restricted exercise. And so I don't know what to make of it.
Right. Okay, why don't we start with, move on to our next presenter, Dr. Weil.
We have about 30 minutes left in the presentation.
All right, thank you.
Okay, you can see it?
Yes, perfect.
And I changed, someone said they couldn't hear me well on my earbuds, so I switched to this. Is this better?
Yeah, that's perfect.
Okay, great. I was just going to kind of give an update about what we've been doing in our research group and kind of talk a little bit more about some of our studies. So I'm actually not going to talk as much about this. We talked a little bit about NTC518 testing. It's something that we're interested in. Our group is interested in basic research, but we're also interested in understanding and applying that to clinical aspects. So I'm gonna skip through this. We just talked about the variable in the specificities, and that was one of the questions that we were very interested in, is that different studies have different specificities for SIBM. And it's also found in other myopathies. And then Dr. Mozafar and Goyle studies suggested there was worsening outcomes. And so we tried to ask this question and answer it on our own. And I'm just going to skip through it. We have, as Washington University has a testing lab, I haven't seen 5,000 patients, but we've tested 5,000 patients for NTC51A. And so we wanted to actually use that rich cohort and just see how it predicted clinically. So not doing it on a research basis, but actually going through the clinical charts. And so what did we see? NTC51A was positive in about 80% of our patients with IBM. That means that 20% weren't positive. So it's not a perfect diagnostic test. And if you don't have an NTC51A antibody, it doesn't mean you don't have IBM. It means we're just learning what this antibody is doing. And that's why Dr. Mozafar's study is so important to really understand the trajectory of these patients. So one thing that we did find, which we thought was interesting, is that 21% of patients with sporadic IBM did actually convert from being negative to positive after 1 year. And so if this does become a diagnostic test, and I'm not saying it is at this point, it would not be unreasonable if somebody was negative or if somebody wasn't responding to corticosteroids and they thought that maybe they didn't have IBM, it wouldn't be unreasonable to recheck them. I'm not sure if people were to look at this, you might say, well, that means it's a really bad test because it changed after a year. And I think that's another fair way of looking at it. But it's also possible that patients actually convert and it can be used diagnostically. So that was one thing that was interesting. We didn't see any difference in outcome measures. And as I said, could NCC5 replace biopsy? Not at this point, but it sure is interesting that if you have biopsy features of IBM, you're most likely to have an NTC51A antibody. So I don't want to belabor the testing because we already kind of talked about it. What I wanted to talk about was some of our laboratory studies and really understanding why protein aggregates accumulate in inclusion body myositis. And so this is I think you guys can see my pointer. This is a muscle biopsy of a patient with inclusion body myositis. This is a muscle fiber and a muscle fiber. This is a muscle fiber. These little teeny guys are muscle fibers. These are atrophic fibers. And the things that we notice in patients with IBM are that there are all this kind of inflammatory cells. So these are inflammatory cells that are invading this muscle fiber here. But the other feature we talk about are protein inclusions and vacuoles. And so this is a fiber that has a vacuole in it. This is a fiber with these kind of dark red inclusions in it. And that's one of the features we're interested in trying to understand is why muscles degenerate. And we think these are degenerative features that we can see in patients' muscle. And we can highlight these a little bit better by using specific stains. This is an antibody stain, kind of looking to see what these inclusions could be. But one question is this is me taking my best guess and saying what I think is there, and then using an antibody, so testing to see what is there. But could we do it in an unbiased way? And so what we did is we did an approach where we could actually do laser microdissection, so we can actually look under the microscope. I can point a laser. I'm not actually pointing it. I tell the computer to do it, but I point a laser at this region right here, or I point the laser at this region right here, and I can collect this part of the muscle. I can collect this part of the muscle. So this part of the muscle doesn't have an aggregate, and it is a fairly normal appearing muscle fiber. This is an aggregate. I can collect it. This is a fiber that has aggregates in it, but this area doesn't. And I can say, what are the difference in the amount of proteins that are there? And so we were able to do this approach. You might say, what did you find? We found a lot. We found a lot of proteins. And so basically what you're doing is you're taking that aggregate and you're asking how many proteins are there, what proteins are there. And so maybe it was naive to think that we'd find 5 proteins that are specifically there. We didn't. We found thousands of proteins, hundreds of proteins that were there. And so this is where you have a problem. It's not a bad problem, but it's a problem that requires then being a little bit more sophisticated about how you identify what's going on there. And so you can take this data and you can put it into different categories. So this is an example of where you can say, well, the proteins that were enriched were proteins that are involved in structure of the protein. The proteins that were enriched were proteins that are involved in helping to recycle the protein, the cell. So you can organize it that way. I mean, that's very helpful to say what categories of proteins are accumulating, not what single protein is accumulating. The approach that we took was actually to leverage kind of our genetic databases. So we were able to take the proteins that we thought were the most enriched across 18 different patients. And so it wasn't just a single patient we were looking at the enrichment of proteins that we found that were commonly enriched across 18 different patients compared with control patients. In that list, we found about 200 proteins. We then took that and we did genetics on these patients, and we're able to overlay the genetics from those patients and say, well, what mutations or variants were in those patients that would suggest that there was something perhaps going on with that protein. We then had to actually take it and use another data set because you need to make sure that the mutations you found weren't just randomly in anybody. So we actually used another patient cohort that we had genetic data on that was similar to IBM, but not IBM. And we ended up finding one protein that we thought was important, was both enriched in protein aggregates and was mutated or had missense variants, meaning that it had a point mutation that might affect the function, and that we found that in patients with IBM, and that it wasn't present in our control population. And so if we go back and then look and say, well, now I should be looking at this protein, FICO1, that's what we did. And so we found that FICO1 localized quite well and quite specifically to vacuoles and protein aggregates. And you can see that here. This is now an aggregate, a vacuole. These are vacuoles and aggregates, and you can see that FICO1 localizes to them. The interesting thing about FICO1 is that it also localized to proteins that are involved in autophagy. So we talked a little bit about autophagy, and I wanted to kind of show this. Autophagy is the way that a cell says this protein, for example, maybe this aggregated protein here needs to be degraded, needs to be taken and put into a trash can and thrown away. And so that process is done by a very elegant and sophisticated process called autophagy, where basically the cell takes a region, so this is now a region of the muscle fiber, and it creates a membrane that forms around that. And so now it's encapsulating it in the trash can, and then it takes the trash can and it moves it and takes it actually to the trash. And so this is the lysosome. This is where there are a bunch of acidic areas that then degrade these proteins. And what does FICO1 do? FICO1 is responsible for taking out the trash. It's this protein right here. It's responsible for trafficking the autophagosome to the trash can. And you can imagine if there were mutations in this protein that you might get accumulation of trash. And so that's actually what we see here, where we can see that FICO1 accumulates with the autophagosome, so accumulates with this and doesn't, we think, mature it to the autolysosome. And so what does that mean? That means that potentially focusing on this as a therapeutic target, so not just enhancing autophagy as what rapamycin might do, but maybe what I call facilitating autophagy might be more appropriate, in identifying drugs that might help move this forward would be another idea. The other thing that we did with this data is we tried to say, well, we've got this huge amount of proteins, and we can narrow them down to a single protein like we did here. We can put them into categories of proteins like we did here. But what if we do something different? What if we say, well, what is similar about these proteins? Meaning, how are these proteins that are enriched in areas, how are they similar from a biophysical standpoint? Meaning not how are they similar in what they do, not how are they similar in a single process, but how are they similar as just a biophysical group of proteins, meaning are they more aggregate prone? So these proteins, are they more aggregate prone? And indeed, as you would expect, as you move from this region to this region, they become more aggregate prone. And this is just a way of looking at that with a complicated algorithm that I needed collaborations to help with. But basically, this is showing you that as you move to the aggregate, the amount of proteins that get there become more aggregate prone. And so that's interesting. But our bigger question was, well, what if we do then now take and go back and look at what proteins aggregate more and what proteins are more abundant. And so typically most of these abundant proteins go down. We think that the muscle fiber is really good at saying, hey, if this protein is supposed to aggregate, we want to get rid of it. So most of these proteins go down or stay the same. There's some proteins that do the opposite. We call these escape proteins. So this is a protein that does the exact opposite. This protein ends up being so we think that this protein could be a driver of the aggregation, and that we think that this driver would be an abundant and aggregate prone protein. And that yellow protein is a protein called desmin. So desmin seems to fit the criteria. Desmin is a muscle specific protein. It has lots of roles. But one question we proposed was maybe if we knock down this driver, once this thing starts to aggregate, if we can stop that cascade from happening, would that be a therapeutic target? And so we've been developing antisense oligonucleotides where we can actually knock down this protein. So this is the protein in a control muscle fiber that we grow in the lab. This is that protein desmin in a patient with an inclusion body myopathy. This is actually a hereditary form, not a sporadic form. You can see it aggregates. And then we tried to now screen. So this is basically doing drug development where we screen different oligonucleotides to see which ones can knock down this protein called desmin. And so we have a couple of good candidates, and we'd love to think about moving this forward into animal models and then perhaps even further. So I just want to summarize that leveraging proteomics and genetics can identify therapeutic targets. Facilitating autophagic degradation may be a therapeutic approach, and our evidence of finding this protein FICO1 suggests that. And finally, we think lowering the abundance of aggregate proteins may be therapeutic. And I'll end with that. I want to thank everybody in my group. And
Okay, thank you very much, Chris. There was a question in the chat regarding whether there are any specific tests that you recommend for actually diagnosing inherited IBM, and also whether there are any treatments available.
yeah, so patients with inclusion body myositis, the name itself implies that it's a sporadic disease. And in fact, we put a little S at the beginning of it, sporadic inclusion body myositis. But there likely are patients who have what looks like sporadic inclusion body myositis and may have a hereditary form of it. And so we have done, as others, and I know Dr. Lloyd has as well, where we have patients that have been diagnosed with inclusion body myositis. I have patients that I diagnosed with inclusion body myositis and then did genetic testing and actually found that they had a hereditary form. That hereditary form has implications, obviously, not just for the patient, but perhaps has implications for other family members. I have now do genetic testing on every patient with sporadic IBM in our clinic. And the reason I do that is because the barrier to testing has been really removed, in that there are free genetic testing programs for hereditary muscle diseases. And so we do this routinely in our clinic. I think the likelihood of having sporadic inclusion body myositis and having a hereditary form, so if you're already diagnosed with sporadic inclusion body myositis, you have a typical presentation, meaning over the age of 55 or 60, with inflammation, the likelihood of having a hereditary form is extremely low, probably on the order of 1%. And so I wouldn't worry if you haven't been tested, but patients that have an atypical presentation, patients that are younger, patients that don't have all the features on their muscle biopsy, definitely need a little bit more scrutiny and need to have hereditary forms. Patients need to know their family histories. And when I say family histories, the truth is IBM is a new disease. It was really clinically and pathologically diagnosed in 1971. And so it's possible that if I were to ask you, does anyone else have inclusion body myositis in your family? You'd be like, no. But does anybody have slowly progressive weakness that led them to using a cane, frequent falls, bedbound, wheelchair over their life? That may be something that could be helpful. And so I think that's another thing to think about that might suggest that something's hereditary.
15 minutes.
Okay, thank you very much. Yeah, let's move to our last speaker, Dr. Alfano.
See if they share the right screen. Yes.
Okay, perfect.
All right, so as I said, I'm a physical therapist at Nationwide Children's Hospital, working in outcome measures and clinical trial readiness activities. And I always like to start with this slide because this is the one question I always get from everyone, including from Dr. Weil yesterday. What is the outcome I should use for my clinical trial? So it's a very multifaceted question that can be hard to answer. But if we're prepared and have enough data, then usually we can make an informed choice. So the same as we wouldn't ask all these animals to climb this tree, we ask different patient groups to try different assessments, and we use different assessments across our trials. So like I said, it's a very multifaceted decision-making process. We're thinking about that particular patient population, what's clinically meaningful, as Dr. Goyle was referring to, for that specific patient population, thinking about other potential causes or sources of variability within that cohort, as well as what is this treatment that we're looking at? Is it targeted, or is it going to have more of a global systemic effect that may differ and change the variable or the outcome that we're selecting? If it's going to be in one muscle, we may target quadriceps strength. If it's going throughout the body, a composite scale may be useful. And then all of our outcomes have all kinds of what we call psychometric properties associated with them. So we have different scales that have pros and cons. If I'm judging a score, so I look at your movement and say, that looks different, I'm going to give it a 1. That has some innate variability associated with it, other than, a timed test where we're saying go and stop. And then again, reducing the burden of testing is really the goal of a lot of our projects. So I'm going to talk about kind of some specific examples of things we've done in IBM, and then also some work we're doing in a hereditary form of inclusion body myopathy. So I like to start with a brief history lesson of outcomes. So the 6-minute walk test is something usually everyone has heard of. And I think this is another example of kind of guessing with science. So this started as a 12-minute test in the armed services in the 1960s. And was used for 20 years before someone said, why are we doing 12 minutes? Do we need to do 12 minutes? And so that person had everyone do the 2-minute, the 6-minute, and the 12-minute. And their conclusion was shorter times are easier. Love science. They're as reproducible, but they might discriminate slightly less well, which I'll talk about, and they have less of a training role. So the discriminate slightly less well is they found that the longer people walked, the more variability there was in that final distance people went, because as they attributed that to fatigue. So what they decided was the 6-minute walk is a sensible compromise, and thus the 6-minute walk test was born. And then we've used it for years and years and years. When I was starting this position some years ago, I was doing the 6-minute walk test in our natural history study and our patients with sporadic inclusion body myositis. And I noticed everyone was walking at the same speed and thought, do we need 6 minutes? Is this giving us any additional information, or should we try something shorter? And since then, we've moved on to other tests as well in other neuromuscular populations. So timed abstract tests in patients with pediatric forms of muscular dystrophy aren't necessarily the most consistent. We all do a little bit better if we have a finish line. So we continue to look at other options. So the short answer is, do we have to do 6 minutes? No. Here's our graphs from our cohort of patients with IBM. You can see this lovely consistent walking speed. We did have a slight decline, less than 5 meter difference in the first 2 minutes of the 6 minute walk test. But again, not significant. And then we don't really gain extra information from the rest of the test. And then looking at correlations, it correlates nicely to all the muscle strength because you have to use your legs to walk, and other functional tests. So both are providing us equal amounts of information. So really the 6 minute walk test is only useful in patient cohorts that really are kind of struggling to walk for a period of 6 minutes. And then we do start to see some fatigue, which potentially could be improved with a therapeutic. But I do also want to just stress that these outcomes aren't just for research. So clinical care is equally or sometimes more important than some of the things we're doing for research. So frequently we will hear from our patients that they feel out of control. They've got this diagnosis, there's nothing I can do about it, and it's frustrating. And so these natural history trials, I think, give some empowerment to give back some level of control for certain actionable items and to be a little bit proactive in care versus just waiting for the next thing to happen. So we were able to kind of model what this disease progression looks like and what are critical factors impacting some critical functions. So when you're thinking about walking tasks, yes, you use all of your muscles in your legs to walk and your trunk and your arms. But the most important factors were hip extension strength, knee extension strength, ankle plantar flexors. So again, not entirely surprising. You need your hips, your knees, and your ankles to walk. But body weight did impact the distance that people were able to walk into in 6 minutes. And while it's not easy, sometimes this is something that is a little bit actionable for patient cohorts. So having the ability to work with the multidisciplinary team to develop that exercise plan, nutrition plan, to keep the strain on muscles as low as possible, to continue walking as long as possible can be really helpful. Similarly, we found standing up from a chair, the most important muscle was not quadriceps in IBM, which you would think. It's actually elbow extension strength. And I think that this points at some of the great compensatory strategies that bodies come up with to continue to do tasks in the presence of weakness. So by monitoring not only lower extremity strength, but upper extremity strength as well, we can kind of proactively monitor and prescribe equipment that may be needed to help with this so that patients still have that independence without kind of losing this ability. So with that, I just want to shift to talk about some of our exciting projects in response to this pandemic, which no one has enjoyed, but some positives are coming out of it. So I mentioned earlier that we are doing a clinical trial readiness study in an inherited form of VCP, multisystem proteinopathy. So they have inclusion body myopathy. And so what we're trying to understand is what outcomes are useful in this cohort. We're also trying to understand variability in those outcomes. So we're doing that within the clinic in a day 1, day 2 visit. But we're also interested in, can we shift the future and do some of these outcomes remotely? So we're doing as many outcomes as possible within a home environment across 2 days. And then we're doing all 4 of those visits within a 2 to 4 week period of time to compare what we see in the home to what we see on site. And then we're continuing to follow patients over 1 year to kind of validate progression and sensitivity of these measures to that progression over time. So we have finished the baseline phase in 24 patients. They're about 50 years of age, more females than males, and they've had a mean symptom duration of 8 years, but they've kind of spanned a wide range of abilities. So we're doing, as you can see, on the left here, we have a battery of tests we're doing. So we're not entirely certain what will be best in this cohort. There are slightly fewer things we can do in the home environment. So our 100-meter time test that I referred to earlier requires a 25-meter track, which isn't available in most homes. We haven't been doing stair climbing activities because sometimes those are available, sometimes they're not, and we don't really want patients stopping in the middle of stairs and turning around and having that safety concern. And then some of our other tests require some very specialized equipment that is less feasible to get into many homes.
5 minutes.
So the process is everything. We've got a nice system set up where we have kind of practice calls. We ship all their equipment to their homes so that everyone is prepared and ready for our testing day. What we're finding is tests are feasible within the clinic and within the home environment. So this is some data from our clinic tests. I think what I want to point out when you're thinking about outcomes is meaningful is important, but you also need to consider the cohort that you're including. So time to rise is we time how long it takes to get up off the floor, but only 50% of our patients can do that. So it's really, while meaningful, it's only useful in a small cohort. And then if you look, we also have a ceiling effect. So those that are able to get off the floor can do it pretty quickly. And then there are some patients that it takes a bit of time, but then they lose the ability. So these tests may only be useful in a really small portion of a cohort. But what's exciting is that our test retest between in-clinic and remote visits is really high. We're asking patients to rate their abilities, so their own impression of change between our day 1, day 2 visits. And as you can see on my graph here on the right, most patients don't see a change within those days. But patients that come to the clinic feel a bit improved. 3 of them felt improved, and 2 of them in the remote environment felt a little bit worse, which is interesting. This could be because of a variety of reasons. We like to think it's because we are charming and make people feel safe and confident in their abilities within the clinic environment. But we'll continue to watch this. So, is remote testing feasible? Yes, it's completely feasible, but there are things to consider. So we have nice high test retest reliability within the home, but we can't do every assessment. We can do things safely, but sometimes we don't always have a caregiver or a helper in the home, which makes us a little bit concerned, especially if there's some tests that could have, balance or fall risks. There is reasonable reliability when compared to our clinic environment, but we do see a little bit more variability between the clinic and home environment, especially for the time to up and go and the pull. So this is a plot that looks at some of the variability between days. So being at 0 is good. And you can see when patients are on-site only, we're closer to that 0 line. When we compare our on-site and remote visit, we start to get some stray variability and differences. This is likely due to differences in equipment, whether chairs in the home are harder than chairs in the clinic. We're not really sure. We'll continue to look at. But something we're considering when we think about maybe different trial options moving forward. So standardized use of outcomes is useful in both clinical care and research environments. I think the pandemic, while is mostly negative, has pushed the field to make some positive changes. So we're continuing to look at maybe hybrid or remote only clinical trials for the future. What's the feasibility of that? Ability to expand trial access with remote visits, so it reduces the burden of participating in trials. You can potentially reach patients that can't get to these centers of excellence. But we do need to validate what we're doing and not just jump in completely. But efforts are underway to do that. So with that, I'll pause. Take any questions.
Okay, thank you all. Thank you so much to all the speakers. And sorry, we're almost out of time. We've had a few questions on actually growth hormone, human growth hormone, somatotropin, genotropin. Does anyone have any experience with this? People are wondering why it hasn't been actually tested in IBM. I don't have any experience with it. By the silence, I'm assuming no one else does either.
So Tom, if I may respond to your comment about the oxandrin or oxandrolone.
Oh, please. Yeah.
I've used it from time to time, especially in cases where we don't have an active treatment. The bigger challenge with getting oxandrolone is the insurance restrictions. It's only approved by FDA for HIV and for children with muscle wasting diseases. And you pretty much have to get a nutritional consult, keep a food diary, and almost impossible to get it approved by insurance for use. It's a fairly benign drug. It was studied in Duchenne muscular dystrophy by Jai Fenichel. Very minimal side effects, but again, the bigger challenge is there's just too much wasted time trying to get it approved by the insurance.
Okay. All right. Any last comments? I think we're going to be cut off in 1 minute.
More like 8 seconds. I'm
8
sorry.
seconds. All
Thank
right.
you so much, Dr. Lloyd, for
Absolutely.
moderating. Thank you, panelists, for being part of today. Thank you, audience, for asking the questions. It's always a pleasure. And this session has ended. Enjoy the rest of the conference.
Okay. Thanks, everybody.